Welcome. We're going to chat about the cardiovascular system. This is Denise Hubble, respiratory therapist. The heart works very closely with the lungs. The lungs bring in oxygen, which gets into the blood and gets carried around the body to the tissues by the cardiovascular system. Just as an overview. The heart is considered the pump, and then we have vessels. Inside of vessels we have blood, which circulates around the body to distribute all the things that the cells of the body need and pick up waste products and take those to their destination from all the tissue cells. It is hard to believe that the heart is so small considering the huge role that it plays in our body. A little bit of terminology. The base is actually the top of the heart and is sort of pointing towards the right shoulder. The apex is the bottom of the heart, kind of a point shape, and is directed towards the left hip. This is an excellent image of the heart in the thorax. We see that it's central and off to the left a little tiny bit. It's between the lungs, and the great vessels are above the heart. Some of the great vessels are known as the superior vena cava and the aorta. Here we have some layers that are outside of the heart. We can start with the outermost, or the most superficial. There is the fibrous pericardium. It's more loose. And then we have the parietal layer of the serous pericardium. And then pericardial cavity, which is not air-filled like it looks like in the image. It actually has serous fluid in it. And then there is the visceral layer of the pericardium, which is also known as the epicardium. Those things mean the same thing. And then we have the myocardium, the actual heart muscle that does the work, and the endocardium is on the inside of the heart wall. And then, of course, we have the heart chamber where blood is. There are 4 chambers of the heart. There are 2 atria, right and left, and 2 ventricles, right and left. And the atria receive blood. For example, the right atria is going to receive blood from the superior vena cava and the inferior vena cava, and the left atrium is going to receive blood from the lungs, actually. The role of the atria are to assist with filling the ventricles, to fill the ventricles a little bit more before the ventricles contract. Generally, the pressures in the atria are lower. The ventricles are the harder working chambers of the heart. There's a right and a left ventricle. And in fact, the left ventricle is the hardest working chamber of all. So there are 4 chambers, and the left ventricle is the hardest working. They could be termed discharge chambers because they eject blood, and they're very thick-walled. They have very strong muscle, and during contraction, blood is propelled outwards. For example, the right ventricle, when it contracts, it propels blood into the pulmonary artery, which is going to go to the lungs. The left ventricle, when it contracts, it propels blood out into the body, through the whole body. There are walls in our heart between the atria and between the ventricles. And if you've heard of somebody with a hole in their heart, it's possible that that may be referring to an opening in one of these walls, causing some blood to leak across that wall. So the wall between the atria is known as interatrial septum, and the wall between the ventricles is known as interventricular septum. The second one is the one we talk about more commonly. The interventricular septum we'll be referring to quite a bit. This is one of the most important slides in the entire general anatomy and physiology course. We need to have an excellent comprehension of this anatomy and have the ability to draw this anatomy from memory. Having such a high level of understanding of the heart anatomy will help you understand what happens when, for example, the tricuspid valve has regurgitation, or the aortic valve has stenosis, or a patient has had a myocardial infarction. All of these pathologies are based on the idea that you have to really understand the anatomy to start off. So let's start in the patient's superior right-hand side. We have the superior vena cava. It's colored in blue because it's bringing deoxygenated blood down from the upper portion of the body. It's dumping that blood into the right atrium. Inferiorly, we have the inferior vena cava bringing deoxygenated blood up from the lower portion of the body. It is also dumping blood into the right atrium. So both the superior and inferior vena cava are dumping blood into the right atrium. We also have a little spot here called a fossa ovalis, and that is a closed flap that is between the two atria, and it should be closed and sealed up in healthy individuals. And when we were a fetus, actually there was an opening there called a foramen ovale, pardon me, and shortly after birth our circulation changed from fetal circulation to adult circulation, and that closed, and then once it's closed fully and sealed shut is called fossa ovalis. Okay, so we're in the right atrium. We know there are generally lower pressures in the right atrium, and the atrium's job is to fill the ventricles. So let's do that. We're going to go down through the tricuspid valve shown in white, and this is a one-way valve, and the blood is now entering into the right ventricle. The right ventricle is a chamber that will have slightly higher pressures, and it has some structures in it, including papillary muscle shown at the bottom. They look like pink mountains, basically. The papillary muscles have chordae tendineae, which are strong like guitar strings, and these chordae tendineae attach to the leaflets of the tricuspid valve to offer support. Think of yourself on a windy, rainy day when you have an umbrella, and don't you wish you had some strings to hold the edges of the umbrella down so it wouldn't invert in the wind? This is the same idea, similar idea. These chordae tendineae offer support to the edges of the cusps of the tricuspid valve. Now the blood is going to need to leave from the right ventricle up into the pulmonary artery. It goes through the pulmonary semilunar valve, also known as the pulmonic valve. Goes up into the pulmonary artery, which bifurcates into the right pulmonary artery and the left pulmonary artery. That blood's going to go out to the lungs and get oxygenated. Okay, what happens next? That oxygenated blood needs to return to the left side of the heart. We see 4 pulmonary veins. They are in red, and they're kind of shown as if they're behind the heart a little bit. Those 4 pulmonary veins are going to dump oxygenated blood into the left atria. From the left atria, the blood needs to go through the bicuspid valve, but more commonly we call that the mitral valve. I think of that as the mighty mitral valve because it needs to withstand high pressures caused by the left ventricle squeezing. Anywho, the blood leaves the left atrium, goes down through the bicuspid or mitral valve into the left ventricle. Look at the musculature on this left ventricle. It has thick muscle because it has to contract really well. We have similar structures here with the papillary muscles and the chordae tendineae supporting the leaflets of the valve, the mitral valve. Now blood is going to leave through the aortic semilunar valve and go up into the aorta at the top. The aorta is a large vessel shown in red, and this is where all blood that's going to go out to the tissues must pass through. Arteries carry blood away from the heart. Veins carry blood towards the heart. And the heart functions as 2 pumps. The right side of the heart pumps blood into the pulmonary circuit, into the lungs. The left side of the heart pumps blood out to the body, the systemic circuit. If you've ever heard of a saddle embolism, it means a large blood clot that is the shape of a horse's saddle sitting in this bifurcation of the pulmonary artery where the artery splits into right and left. It is such a large blood clot that no blood flow can get through. As you can imagine, this is a fatal disorder, and because we've stopped all blood flow to the lungs. So if that helps you kind of understand about the blood flow leaving the right heart needing to go to the lungs, then that's awesome. The blood that was oxygenated by the lungs returned to the left side of the heart via the left atrium, then through the mitral valve, left ventricle, aortic valve, and then to the aorta to get pumped out to the entire body. Our body needs oxygenated blood delivered to it. All of our tissues need that to support metabolism and life. This is a large job that the heart has to do, and the chamber most responsible is the left ventricle. So we understand then why the walls of the left ventricle are so thick, because it has to contract so well to generate high pressures to push that blood around the body. And then we know that once the tissues have used oxygen from the blood, we have deoxygenated blood now, it needs to return to the heart. It gets dumped into the right atrium through the superior vena cava and the inferior vena cava. This is a great image showing the relationship of the heart with the lungs and the body, and we see again that the right side of the heart has deoxygenated blood shown in blue, and that blood needs to get to the lungs to get oxygenated, which now is going to show the blood is red. That red blood is going to return, or oxygenated blood, pardon me, is going to return to the left side of the heart and get pumped out to the body. These 4 valves we'll talk about lots. They are supposed to allow blood only in one direction. They're supposed to open when pressures on one side exceed pressures on the other, and then they're supposed to be able to close shut. We have atrioventricular valves, or AV valves, obviously between the atria and the ventricle. On the left side it's called bicuspid or mitral. On the right side it's called tricuspid. It has 3 leaflets. So the bicuspid has 2 leaflets, the tricuspid has 3 leaflets. The semilunar valves are between the ventricles and arteries. So the pulmonary semilunar valve is more commonly called the pulmonic valve. It is where blood enters into the pulmonary trunk or pulmonary artery. And the aortic semilunar valve is the valve where blood enters into the aorta. The AV valves have that amazing structure I talked about, where there are papillary muscles in the ventricles with these chordae tendineae, or they look and feel like guitar strings attached to them, in order to support the leaflets. These AV valves should be open during diastole, which is known as heart relaxation. And this is when blood is filling the ventricles. And they are supposed to be closed during ventricular systole, or ventricular contraction. When the ventricle is contracting, it's creating high pressures, and it should snap those valves shut. The semilunar valves are closed during diastole. They're calling it heart relaxation here, but more commonly we would call that diastole, and open during ventricular systole. The valves open and close in response to pressure changes in the heart. An excellent explanation about the AV valves. So we know that blood returns to the atria on both the right and left side, and they push the AV valve open, and that allows blood to go into the ventricles. As the ventricles fill, the AV valve cusps are just hanging limply, as it describes, just hanging down and allowing blood to go through. Then the atria are going to contract, and they're going to force a little bit more blood into the ventricles. The AV valves are still open, but next, in point number 4, the ventricles are going to contract. This is going to create high pressures in the ventricles, and it's going to force blood against the AV valve, and it causes the AV valve to close. The chordae tendineae are tightening, and they tighten because of the papillary muscles. Actually, the papillary muscles are contracting, and it pulls on the chordae tendineae and prevents those valves from everting or inverting. I just want to emphasize the importance of this slide and the previous slide, because they come up a lot in a course called hemodynamics. Also, they are tested a lot on the upcoming tests, so it's really good to study these 2 slides very well. Here we have the semilunar valves. During ventricular contraction or systole, high pressures are generated in the ventricles, and this pushes the AV valves open, as is mentioned in point number 1. In point number 2, during ventricular diastole or relaxation, the ventricles are relaxing, the pressure is dropping in the ventricles, and the blood above them in the arteries pushes back on the cusp of the valve and closes them. Also, I want to add here that the coronary arteries fill mainly during diastole or relaxation of the ventricles of the heart. So that's a good point to know, and that there are many test questions on the coronary circulation. It is really interesting that the blood that passes through the heart, through these chambers, does not nourish the myocardium. It does not supply oxygen or glucose, for example, to the myocardial cells. In fact, the myocardium needs its own blood supply, and that is called coronary circulation. We have coronary arteries. These are very, very important vessels in our body. In fact, kind of think of atherosclerosis in the coronary arteries as our kryptonite as Westerners, because most people in Canada and the US have problems with the accumulation of atherosclerotic plaque in their coronary arteries, thus diminishing blood flow to the heart to the myocardium, specifically of the heart. Anyway, coronary arteries branch off of the aorta and supply the heart muscle with oxygenated blood, true enough, and cardiac veins drain the myocardium of blood. We're not nearly as concerned about cardiac veins as we are about the coronary arteries. The coronary sinus is a larger vein that receives blood from all the cardiac veins and then dumps it into the right atrium. Don't let this image overwhelm you because we actually already know a lot of these terms. Perhaps we'll go in a clockwise fashion, starting at the top. The brachiocephalic trunk is a branch off of the aorta. The left common carotid and the left subclavian artery are also branches off the aorta. We do need to know how to label these and what order they're in. The aortic arch is shown there. The ligamentum arteriosum is a ligament between the aorta and the pulmonary artery, and it is left over from fetal circulation. That was actually a patent vessel or open vessel when we were a fetus. The left pulmonary artery, we already know about that. It is going to the left lung. The left pulmonary veins are coming from the left lung. There's the left atrium. And then now we're going to get into some of the coronary arteries. The circumflex artery is a coronary artery. The left coronary artery is shown here as well. Some will call that the left anterior descending artery. Next we have the left ventricle, we know that. A vein, cardiac vein, we won't have to label those. They're not as important. And there's the left anterior descending artery shown again. The apex of the heart is at the bottom of the heart. Now, starting over on the patient's right, at the lower portion of the slide, we have the inferior vena cava bringing deoxygenated blood back from the lower part of the body. We've got a vein, we don't need to know the names of those. There is the marginal artery of the right coronary artery. So it's a branching, it's a marginal branch off of the right coronary artery. And then we have the right ventricle labeled. There's a vein, we don't need to know about that. And then we have the right coronary artery labeled, and right pulmonary veins coming from the right lung, and we've got the pulmonary trunk, also known as the pulmonary artery, which takes blood from the right ventricle out to the lungs. And then we have the ascending aorta, that's just the beginning portion of the aortic arch, and the right pulmonary artery taking deoxygenated blood to the lung, the right lung, superior vena cava bringing deoxygenated blood down from the upper part of the body. The heart has its own conduction system known as the intrinsic conduction system. The reality is the cardiac muscle contracts spontaneously and independently of nerve impulses. This is simply amazing. We do not need a nerve to go to the heart to tell it to beat, because it will know to do that. So spontaneous contractions occur in a regular and continuous way normally. Atrial cells are going to beat around 60 times per minute. I'd actually say 60 to 100 there is the normal. And ventricular cells are going to beat at 20 to 40 times per minute. Well, that would be their set timing that they would beat at if they weren't told otherwise. But typically the atrial cells are going to pass information down to the ventricles and tell them when to beat. They need a unified control system, and it's called the intrinsic conduction system or nodal system. The autonomic nervous system has an impact on the heartbeat, the heart rate, for example, but the intrinsic conduction system actually sets that rhythm. So that's important to note, that the autonomic nervous system just impacts it, can tweak it up a little bit or tweak it down a little bit, but it's actually originally set by the intrinsic conduction system. This system sets the heart rhythm, the heart rate, ensures that the heart depolarizes in one direction only. It needs to move from the atria to the ventricles. This rate should be between 60 and 100 in normal adults. There are many parts of it. They're really interesting. The SA node, the sinoatrial node, is located in the right atrium, and we call this the heart's pacemaker. This is where all the magic begins. So this is where the beat starts, or the impulse starts. The AV node is at the junction of the atria and ventricles, so right between them, and then the AV bundle, or the bundle of His, and the bundle branches are actually in the interventricular septum, that wall between the two ventricles. The Purkinje fibers spread throughout the ventricles, the ventricular walls. Excellent. This is a great picture of the conduction system of the heart. We're starting at the patient's top right. The SA node is the pacemaker of the heart. It is in the right atrium. It sets the heartbeat of the heart and sends the impulse out. The impulse travels through the atria and then down through the AV node, and then through the AV bundle, also known as the bundle of His, and then through the Purkinje fibers that are throughout the ventricles. This is so important. The SA node starts each heartbeat, and then that impulse travels through the atria, like I said before, to the AV node. That impulse tells the atria to contract, tells the muscles, it's time for you guys to contract. At the AV node, the impulse is delayed for a moment intentionally. So there's a little delay there. I think of it as a little bridge to walk over. So the impulse is delayed. Now the impulse travels through the AV bundle, down through the bundle branches, and the Purkinje fibers. This tells the ventricles to contract, and blood is ejected from the heart. Let's talk about electrocardiograms, ECGs, or EKGs. They all mean the same thing. This can be done with some electrodes applied to a patient's chest, and we can take a look at the electrical activity of the heart. Let's look at the graph here. The x-axis is time, so on the bottom of the graph we're looking at time, and the y-axis, the up and down axis, would be electrical activity. As electrical activity moves through the heart, we are reading it with our electrocardiogram. The P wave is indicated by electrical activity passing through the atria, and it is called atrial depolarization. The QRS wave represents ventricular depolarization. It is when electrical activity is passing through the heart and telling the heart muscle to contract. The repolarization of the ventricles, which is kind of like recharging them and getting them ready to depolarize again, it's called repolarization, is indicated by the T wave. So you can see that we look at P waves reflecting the atria, QRSs reflecting the ventricles. And we'll have a course at some point on ECGs, and you'll learn all about this in more detail. I'm going to use these terms over and over again, systole and diastole. So let's take a look at how this works. The cardiac cycle is occurring over one heartbeat. Both the atria and ventricles contract and then relax, and we use these terms systole and diastole. But I really need to clarify, generally when we say the word systole, we're referring to ventricular systole. The ventricles are the ones doing the big work, so we kind of give them the lead on that. So when we talk about diastole, generally we're talking about ventricular diastole or ventricular relaxation. The average heart rate is 60 to 100 or around 75, and that makes the cardiac cycle around 0.8 seconds. That means that systole and diastole must occur during a 0.8 second cycle. Oh, this is great stuff. During the cardiac cycle, the atria at one point are relaxed and the ventricles are filling. The whole heart is relaxed right now, and the pressures in the heart are low. The AV valves are open, allowing blood to spill easily from the atria down into the ventricles. The semilunar valves, though, are closed. Those are the valves that open into the pulmonary artery and the aorta. They're closed right now. Next, the atria are going to contract. When the atria contract, they're squeezing blood down into the ventricles and really kind of wringing themselves out and squeezing that last little bit of blood down into the ventricles. We call this atrial contraction, and just note that the ventricles are remaining relaxed right now. They're just relaxed, they're in diastole, and they're receiving blood from the atria. We also call this atrial kick. That term is referring to atrial contraction filling the ventricles. Here's a big term, isovolumetric contraction. Don't let it scare you though. Isovolumetric just means same volume. Iso is same and volume, of course, is there. So same volume contraction. So what's happening is the ventricles now are going to contract, but we're going to keep the same amount of volume in the ventricles for a moment. So let's take a look at that. At this time, atrial contraction ends and ventricular systole begins. The pressures inside the ventricles rise, and the AV valves are going to close at this point. For a moment, the ventricles are completely closed chambers. All valves are closed at this time. That's why it's called isovolumetric, because the volume in the ventricles is the same, it's unchanging. This will only last for a moment. Next, we have a phase of the cardiac cycle where the ventricle continues to contract, and the pressures now are getting very high in the ventricles, and they are able to surpass the pressures in the aorta and the pulmonary artery. So now the semilunar valves open and blood is ejected out from the ventricles to those big vessels. At this point, the atria are relaxed and filling with blood simultaneously. Now the ventricles are going to relax. When the ventricle begins to relax, the pressures drop inside the ventricle and the semilunar valves snap shut. And for a moment in time, in fact, all valves are going to be shut. This is called isovolumetric relaxation. Isovolumetric is same volume because all valves are closed. And then next, what is going to happen, or at the end of this phase, the AV valves will open. If we were to listen to your heart, we would be able to hear these sounds: lub-dub, lub-dub, lub-dub. The lub, it is believed to be a sound that is generated by the closing of the AV valves and the turbulence and blood flow that creates. The dub is a sound that we hear that we believe is caused by the closing of the semilunar valves, and it creates this vibration as well. This is such a great image. I just love this. So number one, we're looking at atrial relaxation and ventricular relaxation. The whole heart is relaxed and blood is spilling down from the atria to the ventricles passively. Number two, the atria are going to contract. They're calling it systole here, which is fair enough, but we could think of it as just contracting. The atria are contracting. We call it priming the pump. They're squeezing a bit of extra blood down into the ventricles to superfill the ventricles. Number three, isovolumetric contraction. The ventricles are contracting. They are in systole. When they contract, they generate high pressures. It snaps the AV valve shut, and for a moment, in fact, all valves are shut. Isovolumetric, all valves are shut. We keep the same volume in the ventricles. But the pressures get so high that in point number 4, they actually cause the semilunar valves to pop open so that blood can be ejected into the great vessels above, the pulmonary artery and the aorta. Number 5, now the ventricles are relaxing and they're in diastole, and the pressures are dropping inside the ventricles. This causes the semilunar valves to close, and in fact, for a moment, all valves are closed, and that's called isovolumetric relaxation, when all the valves are closed, and then the cycle starts over again. Cardiac output, we'll be talking lots about that in future courses. Cardiac output is the amount of blood pumped out by each side of the heart in 1 minute, specifically the ventricle, and it should be the same. The right ventricle should be pumping out generally the same amount as the left ventricle. Stroke volume is usually around 70 mils, and it's how much blood is ejected from the left ventricle with each heartbeat. So when that left ventricle squeezes, how much blood is pushed up into the aorta, usually around 70 mils. Heart rate is usually 60 to 100 for adults, and 75 here is perfect for an average. Here's the relationship between cardiac output, heart rate, and stroke volume. So if we look at your heart rate, and we'll say it's perfectly normal, 75 beats per minute, and if each of those beats causes 70 mils of blood to be ejected, then that is your stroke volume, 70 mils. And we can multiply these together, and we see that the units cancel each other out. We can cancel out those beats in each case, and we get mils per minute. And that math works out to 5,250 mils per minute, but we always convert that to liters per minute. So 5.25 is normal cardiac output. In fact, our normal that we look at for adults is generally 4 to 8 liters per minute. We'll call that our normal, and most textbooks agree on that. And as you can picture, if somebody has a failing heart, that their pump is now failing. So what do you think happens to cardiac output if your pump is failing? Well, it is dropping. So if the cardiac output is measured on your patient, it may come back to be 2.5 liters per minute. That would be very low, and that's an indication that the patient has pump failure or heart failure. Talk about stroke volume. We mentioned that about 70 mils is pumped out with each heartbeat, but as you can picture, not all of the blood is ejected from the ventricle. It's like a kitchen sponge. If you try to wring the water out of it, there's still always going to be some water left. So it's kind of important to keep that in mind. We're not actually fully emptying the ventricle. Also, a good point is Starling's law of the heart. This will come up over and over again. It is the idea that the more you stretch the heart, the greater the squeeze the heart is going to have. It is a lot like a slingshot. If you used a slingshot and you put a rock in a slingshot and you just pull back a little tiny bit, well, there's not going to be a lot of force ejecting that rock forward. But if now you pull back really, really far, there's going to be a lot of force to project that rock forward. That's the idea of Starling's law of the heart. This talks about the filling of the heart, the stretch of the heart. They mean the same thing. So if you overfill the ventricle, then it's going to squeeze more. Important to note, though, that this is only to a point. You can overstretch the heart too far, where it really isn't efficient anymore and it cannot contract anymore very well. Kind of like a slingshot. If you pulled that way too far back, you would actually have poor ability to have a forward force because you would be too far back and damage to the elastic, basically. Excellent. Well, we know that the heart has its own sort of intrinsic heart rate. It has its own ability to generate a heartbeat, but there are outside factors that affect the speed of the heart, for example. So if we look at the nervous system, sympathetic nervous system stimulation will increase heart rate. You've had that happen probably when you were almost in a car accident at some point and you were very fearful and you had that fight or flight response and you notice that your heart is racing right after that. The opposite of that is parasympathetic nervous system, which likes for us to slow down. This can happen via the vagus nerve. It tends to slow our heart rate down. Hormones like epinephrine and thyroxine can speed up our heart rate. They will speed up our heart rate, pardon me. And high or low levels of calcium, sodium, or potassium can affect the heart rhythm in lots of different ways. There are other factors like age and gender. If you're exercising, obviously if you're exercising, your heart rate goes up, and body temperature causes your heart rate to go up as well. This is an overview of many of those things we just talked about. For example, if we have stimulation of the sympathetic nervous system, that's going to increase heart rate and it's going to increase stroke volume, and both of those things, of course, increase cardiac output. If you're exercising, then that's going to increase stroke volume and actually heart rate as well, so that increases cardiac output. A few other things mentioned here would be that if a patient is hemorrhaging or bleeding out, that's what we would call that, then they have decreased venous return. Venous return is the amount of blood coming back to the right atrium. So if we have decreased venous return, we tend to have lower stroke volume, and that lowers our cardiac output. The blood vessels are basically the tubing in our body that carries blood around. There are three main types. Arteries carry oxygenated blood away from the heart and towards the tissues, and veins carry blood from the tissues back towards the heart. The capillary bed is all through our body, and it is very thin-walled vessels that allow easy exchange of things like oxygen between the blood and the tissues. The blood vessels have three layers. They call them tunics. Sometimes I think of a tunic as a loose-fitting shirt. So It has 3 of these loose fitting shirts on it, if that helps you remember. The tunica intima is on the inside. It's also called the endothelium, and it likes to reduce friction so that the blood can move along very, very easily through the vessel. The tunica media is mostly made up of some smooth muscle. Remember, we don't have to think about smooth muscle. That's under autonomic control. And elastic tissue. This smooth muscle is controlled by the sympathetic nervous system. Increased sympathetic nervous system stimulation causes constriction of that smooth muscle. The tunica externa is the outermost covering. It has a lot of connective tissue, and it supports and protects the structure. If a clinician is inserting a needle or a catheter into an artery or a vein, it's so great to appreciate the differences between arteries and veins. Look at this image. We see that the artery wall is very thick and the lumen is very small. The vein is the opposite of that. The vein wall is very thin and the lumen is very large. Well, one way that we can kind of apply this is think about blood pressure. Arteries are exposed to high pressures. They need to have thick walls. Veins are exposed to low pressures. It's fine for them to have thin walls. Such a fantastic image that compares the arteries to veins. Let's look at the artery first. Well, first of all, we already know it has thicker walls, and we already know that the lumen is smaller. This vessel has to put up with high pressures, so it needs to have a thick wall. We also notice it has a lot more muscle than the vein does. Okay, let's take a closer look. The tunica intima, it does have the the endothelial lining, which reduces friction, but it is good to note there that there's also loose connective tissue and a little bit of elastic tissue there as well. So internal elastic lamina is shown in yellow, looks like Swiss cheese, but that is elastic tissue. Okay, the next layer, the tunica media, easy to remember because it's kind of like a shirt that's in the middle, so tunica media. It has some smooth muscle. In fact, it has lots of smooth muscle in the artery, some elastic fibers, and it has this layer of external elastic lamina that again looks like Swiss cheese to me. It's shown in yellow on here. And then the tunica externa, of course that's on the outside. It has a lot of collagen fibers and it's very strong. All right, let's move over to the vein. Look at that lumen. The lumen is a little larger. The thickness of the vessel is smaller. I don't know if it really represents that well in this image, but we should note that the thickness of the vessel is less. The muscle of the vessel is less, and it has those 3 layers as well, the tunica intima, the tunica media, and the tunica externa. Also, look at the valve inside the lumen of the vein. We have valves inside these veins to help with blood flow going in one direction through the vein, and that is back to the heart. Okay, between the artery and the vein, we have some other structures. Well, arteries get smaller and become arterioles before they hit the capillary bed, and then they go into venules, and then those venules dump into veins, which is going to return blood to the heart. Okay, let's take a closer look at the capillary. Well, we know already that capillaries must have very, very thin walls because there needs to be communication between the blood in the capillary and the cells in the tissues. So yes, indeed that's true. We see the capillary walls are very thin. They're simply a basement membrane and then endothelial cells. In fact, these capillaries are very leaky, and we're going to learn about how much fluid leaks out of them regularly. This is a good review of some of the points we've already made. Something new, though, that's introduced here is the idea that your skeletal muscles milk blood in the veins toward the heart. Okay, so what this means is that when you get up and walk around and use your calf muscles, for example, when those muscles of your calf contract, what they're doing is constricting and squeezing the veins, and this is actually helping pump blood up from your feet up back to your heart. So it's the skeletal muscle activity that helps move the blood through the venous system from at your feet up to your heart. And keep in mind that gravity is making blood want to be down there at your feet, so it needs some ways in order to get the blood back up through the venous system. That's why when I go on a long plane ride, I'm eager to get up and walk around. I really want to use my calf muscles and make sure that I'm having good blood flow from my venous circulation in my legs, moving blood back up to my heart. If we sit still for too long, we can actually get a sort of buildup of blood in that area and get some blood clots, which is not good to have. This picture shows a couple of the things that help with movement of blood in veins. We've already talked about valves. These are one-way valves, they're supposed to be, that ensure that blood flow doesn't go backwards. We have the skeletal muscle contraction, which squeezes blood up the venous system, but we need to add one more point here, and that's called the thoracic pump. The thoracic pump is the idea that when we inspire, we create a negative pressure in our thorax, slightly. And when we exhale, we create a slightly positive pressure in our thorax. And that concept is termed thoracic pump, this variation of pressures in the thorax. And it's understood that because of this variation in pressure, the thoracic pump, that helps draw blood back from the venous system into the right atrium. So 3 ways that help with blood flow in the venous system would be valves, skeletal muscle contraction, and thoracic pump. So we know that capillaries are very thin-walled. They only have a tunica intima, and this allows oxygen, for example, to leave the capillary and go out to the cells of the tissues where it's needed. Also things like glucose, for example, can move out. The capillaries are known as the capillary bed. We could also call this microcirculation. They're very, very small vessels, but there are millions of them. Capillary is the typical type of capillary, which empties into a post-capillary venule. But before that, I should mention that there's a precapillary sphincter. This is like a muscle band at the beginning of the capillary that controls how much blood flow goes to the area. We can see it in the subsequent image. It's amazing that your body can control at that level how much blood flow is going into that capillary bed. It can sort of shut down blood flow to the area or relax and allow lots of blood flow to the area. Capillaries all have the precapillary sphincters, and the capillaries that don't have precapillary sphincters are called vascular shunt. We see them here in this image. If all of the precapillary sphincters close in this capillary bed, then we have a shunting of blood across the system, and it's called vascular shunt. And what happens here is that really not much blood is delivered to that area to allow communication with the cells in that area. So that's termed a shunt. The aorta is a large vessel. I think of it like a garden hose coming off of the left ventricle. It contains all of the blood flow that needs to go out to the body. So it is the largest artery in the body. And it has a few portions of it. The ascending aorta, well, ascending means going upwards, so it's the beginning where we're leaving the ventricle. And the aortic arch, and so that's actually the arch shape. And off of the aortic arch, we've learned that 3 vessels branch off of there. Then we move down to the thoracic aorta, where the aorta travels down through the thorax, so it's descending at this point. And then the abdominal aorta is where the aorta is passing through the abdominal cavity. You may have heard of somebody that has a AAA, or an abdominal aortic aneurysm. What that means is the vessel, the aorta, pardon me, as it passes through the abdomen, it has an area that has become weakened, and there is an outpouching in that area. Those can be dangerous, because imagine if that ruptures, how the blood can spill out very quickly into the abdominal area, and this could be fatal. There are numerous arteries in this image. Thankfully, we don't need to memorize them all. When we work our way downwards through this image, we go all the way down to the femoral artery. Let's be sure that we know that one. But the vessels below that, you do not need to memorize on the right or the left. So any of the vessels below the femoral artery, no need to memorize those. So these are some of the important arteries in the body. Some of them we will be accessing, for example, if you're performing an arterial blood gas, like the femoral artery or the radial artery or the brachial artery. Others are accessed for other procedures that you may be assisting with. So it's good to know the names of most of these. Here we're hitting on the naming of the major veins of the body. We don't necessarily have to memorize all of these, though they're very interesting. Let's make sure we memorize the veins that drain the upper limb, so all of those, and the internal and external jugular veins, and of course the superior and inferior vena cava. We need to know where those are. It's amazing to me that the arteries that go up into the brain actually form a circle called the circle of Willis. This is an anastomosis, we would say, that these vessels join together. Bit of a safety feature for our brain, because if one artery becomes blocked, this collateral circulation allows for continued blood flow as long as the other vessels can still supply it. So it's made up of the basilar artery and the two carotid arteries delivering blood flow up into the circle of Willis. An excellent image showing how blood flow goes by the GI tract and absorbs nutrients and toxins, for example, and then it is carried via the hepatic portal vein to the liver. And in the liver, the hepatocytes work hard to try to deal with any toxins that may have entered from the gut. And then the blood leaves via the hepatic vein to the venous circulation. And back to the heart. Here we see the hepatic portal vein has picked up blood supply that has just gone by the GI tract, and it's going to bring it to the liver first, so the liver has a chance to deal with any toxins, for example. And then the blood is going to go on to the inferior vena cava and to the heart. Vital signs are measured routinely on our patients. They include pulse, blood pressure, respiratory rate, temperature, and many people will say oximetry is a vital sign as well. Let's talk for a moment about pulse. We're calling it here arterial pulse, but most often you'll hear the term pulse or heart rate. So what happens is that when the ventricles contract, they create a high pressure in the aortic side of our body, and that creates a pressurization of the system. Then during diastole, there's relaxation of the ventricles and the pressure drops. So we have this pressure wave or variation of pressures. We can feel that variation of pressures at places such as the radial artery in our wrist. And when we have a feel of that, we know that normal should be between 60 and 100, and that perfect normal might be around 75. There are some points that are fairly easy to assess the pulse at. The ones that we most commonly would use would be the radial artery, first and foremost. It's easy to palpate. It's comfortable for the patient as well. Another spot we could palpate the pulse would be the carotid artery, and another would be the femoral artery, although that would be used rarely. The femoral artery may be palpated during a cardiac arrest, for example, in an unconscious patient. This is an excellent point that was made in the previous slide as well, that there is a pulsatile pressure in the arteries, because we know that the heart or the pump is contracting and relaxing, and we get this up and down of pressures. It is shown on this image with the up and down motion on the graph. And it starts out really, really high, and we see in the aorta that the pressures are around 120/80. The top pressure is systolic pressure, and the bottom pressure is called diastolic, and 120/80 is considered normal. As we move further away from the heart, the pressures drop, and the pulsatileness, pardon me, I'm sure that's not a word, but the quality of there being a pulse to this actually is gone eventually. So in the arteries, we can feel a pulse, and indeed in the radial artery we can feel that. In the arterioles, there's still a little bit of pulsatileness, but once we reach the capillary bed, it's just a steady flow of blood with no variation in pressure. But the pressures are dropping, and we see in the venules and then in the veins, the pressures are getting very low. And once we get back to the right side of the heart via the vena cava, we see the pressures are very low. In fact, some authors will describe the pressure in the right atrium as 0 to 8. Interested in what our blood pressure is, so let's learn what makes up that blood pressure. It is affected by cardiac output, or the amount of blood that your left ventricle is pumping out, and peripheral vascular resistance, or peripheral resistance. That is basically how tight the blood vessels are and how much friction that creates. When we multiply those two things together, it causes your blood pressure to be present. So the way to apply this is if your cardiac output goes up, then your blood pressure is going to go up. And if your peripheral vascular resistance goes up, then your blood pressure is going to go up. If they both go up, then of course your blood pressure is going to go up. The parasympathetic nervous system has no impact on the tone of blood vessels or the amount of contraction of the muscles around blood vessels. Therefore, it has very minimal effect on blood pressure. The sympathetic nervous system has a huge impact on the tone of the muscles around blood vessels. It can tighten them very well. That's called vasoconstriction, or narrowing of the vessels. This increases peripheral vascular resistance, which increases blood pressure. The kidneys regulate blood volume. If blood pressure is too high, the kidneys will release more urine. That's totally true. And if blood pressure is too low, then the kidneys will tend to retain urine. They do that by releasing something called renin, and renin is involved in the formation of angiotensin II, which is a vasoconstrictor, and angiotensin II causes the release of aldosterone, which increases sodium and therefore water reabsorption by the kidneys, which means less urine output. If we have less urine output, we should have higher blood volume, and that should increase our blood pressure. This is going to be hit on again in the renal system. Temperature has an effect on blood pressure because heat tends to cause vasodilation, cold tends to cause vasoconstriction, and epinephrine, separate issue, when epinephrine is released, it causes increased heart rate and therefore increased blood pressure. It also causes vasoconstriction, which leads to increased blood pressure. It's a great overview of things that can impact your blood pressure. So if you have decreased blood volume, that will cause the kidney to try to retain water, which should increase blood volume, increase stroke volume, increase cardiac output, and thereby increase blood pressure. Also, if we have decreased blood volume, that triggers the sympathetic nervous system, which increases stroke volume and heart rate and vasoconstriction, and all of these things are going to lead to higher blood pressure. Exercise does all of those things as well, and postural changes can stimulate the sympathetic nervous system as well to do those three things and lead to higher blood pressure or correct a blood pressure issue. Chemicals like renin, we already started to talk about those. Renin causes a result of vasoconstriction, which increases peripheral vascular resistance, and that increases blood pressure. Also, increased blood viscosity. That's an important one. If you have very, very thick blood, like a patient who is polycythemic, they have a lot of extra hemoglobin, they have very, very thick blood, that increases peripheral vascular resistance, which tends to increase blood pressure. Okay, we're going to talk more about hemodynamics. A little bit more about hemodynamics. If we look in the brain and we study, still talking about the brain. So, just like this kind of looks a little daunting, but actually isn't our body amazing? Interesting that we deal with these issues commonly in our patients. Hypotension is an issue that we deal with regularly in ICU. These patients have low blood pressure. In fact, their systolic pressure is less than 100. Many of the patients that we see have blood pressures of 70/50, for example. This can be a very, very serious issue. These patients need a lot of support with strong medications in order to help them. Hypertension is something we deal more with our chronically ill patients and people in the community. It is a sign that perhaps peripheral vascular resistance is increased. And the current guidelines are 130/80, so anything exceeding 130/80 is considered hypertension. In the capillary bed, there's a very good exchange of things like oxygen and nutrients with the cells of the body. There is interstitial fluid in this area around the cells, so of course these things are moving in and out of the interstitial fluid and then in and out of the cells. Most of it is due to a concentration gradient, just meaning that there's more of it in one area than another. For example, fresh oxygenated blood brought by tissues that have already used up their oxygen, there's going to be a gradient of oxygen. There's going to be a higher amount of oxygen in the fresh oxygenated blood, therefore oxygen is going to leave the blood and go over into the interstitial fluid and then into the cells where it's needed. CO2 does the exact opposite. It's a waste product of our cells, so it builds up out in the interstitial fluid and it tends to move towards the blood. This exchange between the blood and the cells can happen in many different ways, as it's listed here. Often it is a result of diffusion. Okay, we're going to add to this a little bit. Based on Starling's law of the capillary, we know that there are actually 4 pressures to consider when we look at the movement of fluids in and out of capillary beds. And let me just back up for a moment. Capillary beds are very leaky, so fluids can leak very readily in and out of capillary beds. So there are hydrostatic forces. For example, blood hydrostatic force or blood hydrostatic pressure is the amount of pressure of the blood in the vessel wanting to push outwards. It's a physical pressure. The interstitial fluid also has a hydrostatic pressure as well. So interstitial fluid hydrostatic pressure, there is some of that as well. So we have these physical pushes from inside of the vessel outwards and from outside of the vessel inward. Also, there are osmotic pressures. We always think of osmotic pressure as a pull, like a sponge. So if your blood has a high osmotic pressure, it is pulling fluid towards it. This is caused by large solutes present in the blood, like albumin. Albumin is a large protein. It acts like a sponge, as I've said before. So if there's lots of albumin in the blood, it's going to have a strong oncotic or osmotic pressure. They mean the same thing. Strong oncotic pressure is going to pull water towards it into the blood. Well, the interstitial fluid also has a degree of osmotic pressure. It's usually not as strong in the interstitial fluid, but it has some osmotic pressure that will have a tendency to draw fluid towards it. So we really want to talk about 4 pressures here, not 2, because each side of the vessel has its own hydrostatic pressure and its own osmotic pressure. It is the balance between those 4 factors that determine if fluid is leaving the capillary going out to the interstitial fluid, or is fluid leaving the interstitial fluid and coming back to the blood. As a sort of overview of it, if we looked at your whole body, we would see on average 20 liters of fluid per day are leaving the capillary, and going out to the interstitial fluid and being available to the cells. But 20 liters of that is leaving, but 17 liters of it is returning at the end of the capillary bed. So at the beginning of the capillary bed, 20 liters are leaving. At the end of the capillary bed, 17 liters are returning. Now, you might say, where are the other 3 liters going? Well, we have an entire system called the lymphatics. The lymphatics are the drainage system of the body, and we count on them to pick up that excess 3 liters that got left behind by the capillary bed. If our lymphatic system wasn't working well, that 3 liters would be accumulating, and we know that the patient would get quite edematous in that area. Okay, so this slide also hits on that the blood pressure is higher than osmotic pressures at the arterial end of the capillary bed, pardon me, and lower at the venous end of the capillary bed. And in fact, it's the result of all the forces. You know, it's actually taking all the forces in account. There is more force pushing blood out at the arterial end of the capillary bed, so 20 liters per day go out, more forces pulling fluid back to the capillary bed and the venous end, 17 liters per day. And then we're left over with 3 liters per day picked up by the lymphatics. Okay, here we're talking about Starling's law of the capillary. Just building on what we've already learned about, just going to get into a little bit more detail. If we start on the left of this vessel, we have the arterial end of the capillary bed. What happens here is we have a high blood hydrostatic pressure. Here we're saying a number of 36, for example, millimeters of mercury. There's a lot of pressure of the blood, and this is going to tend to push fluid outwards, of course. But the blood also has some osmotic pressure, or oncotic pressure, which tends to draw fluid inward into the vessel. Here they're using a number of 26 millimeters of mercury for that force. The interstitial fluid osmotic pressure, or the pull of water out of the blood vessel, is about 1 millimeter of mercury, and the interstitial fluid hydrostatic pressure, they're using 0. They're saying there's really no tangible amount of pressure pushing fluid into the blood vessel. So in the mathematical formula under arterial end, kind of written out in red here, what they're doing is summing up all of these forces, and they find that the net filtration pressure is around 10 millimeters of mercury. That means when we take all these things into account, that fluid is going to be pushed out of the vessel. Okay, well, when we get down to the blue side of this vessel, what happens then? We have new numbers. Okay, so our blood hydrostatic pressure now is only 16 because there's not as much blood in the vessel anymore, so much leaked out, so much fluid leaked out. Our blood capillary osmotic pressure is 26. Our interstitial fluid hydrostatic pressure is negligible, or 0, and our interstitial fluid oncotic pressure is, they're using 1 there. So when we take all of these numbers into account, we see a negative 9 millimeters of mercury for reabsorption. That means that fluid tends to move back into the vessel. So this math just kind of shows how all those factors sort of can be summed up together to figure out whether water is coming out of the capillary or going into the capillary. Now we know that about 20 liters of fluid leave the capillary bed of our bodies every day, and 17 liters goes back, and that the lymphatic tissue shown in green here picks up the excess 3 liters.